what I saw was a mess. I saw an absolute mess. I saw people who were really having tremendous difficulties. They were making a transition in their 40s, 30s plus. So they were giving up siblings, jobs, families, parts of family, and especially in the case of the male to females, they weren't looking particularly female. They had the height, the hands, the jaw, the zygoma, brow, all the things that made a gender attribution of male. If people said men in a skirt, a lot of them would have conformed to that. There were only the few who were lucky enough to have a frame and features and a voice and whatever that could pass readily as females. The female to males had all gone, had been menstruating, they had full breast development, and the things that I'm talking about right now in terms of adults were really true of the adolescents I saw. Because as you look at the data, you'll see how old the natal girls are when they come to us. The goal was to stop puberty and to gain, we needed time to get more height, but their height ran out early, as it does with females. They were, we'd like to virilize them genitally, but all you can get is about 4 centimeters of clitoral length after about 2 to 4 years of androgen treatment. Suppressing menses, well, suppressing menses can be difficult. It usually works just to give them normative doses of testosterone, but very often, no matter what you do, if they have a uterus, even if you use GnRH analog, if you use testosterone, some of that's going to be aromatized to estradiol and can produce vaginal bleeding anyway, in which case we may end up using tamoxifen, norethindrone, and that's one of the reasons I encourage hysterectomies after age 18 or so, because of the higher risk of endometrial cancer, even if you're on testosterone. There's also a higher risk of breast cancer if you're on testosterone because of aromatization of testosterone into estradiol at the breast. And so you need, and also almost all of them need to have breast removal, because by the time they're a full Tanner 3, there's too much tissue to just leave there. But if you can get them at a Tanner 2 stage and stop the puberty, you actually will get some breast regression and they won't need any surgery. Now, it's a big deal when you get them in terms of wanting to get breasts off, which most people won't do till they're around 16. Why is it that so many of my patients are a D cup? I don't know. My daughter says I have such an ability to say what size people are. I should give it all up and become a fitter at Victoria's Secret. But it really matters, because if a girl or woman has an inframammary fold, then that nipple's going to have to be relocated. Now, to relocate in just a simple reduction, if a woman wants to retain a breast, is easy because it sits on the plane of the skin because there's tissue, breast tissue under it. But to move a nipple to a flat chest requires an incredible skill that hardly any breast surgeons know. They don't do that operation, and if they don't do it right, the areola and nipple complex will sink like a pothole. And besides, women who have a reduction, they may have subcostal scars for the removal of tissue, but in sitting up, those scars are hidden by the breast that's remained. But if you want a totally flat chest, you have to have the full subcostal scars will show, no matter what you do. So getting it early and being able to remove through a single semilunar incision is a big deal.